Hello, my name is David Viveros. I'm a gynecologist in Bogota, Colombia, and today I have the really great pleasure of interviewing Professor David Cibula and Henrik Falconer to talk about total mesometrial resection in patients with cervical cancer. Professor David Cibula is the head of gynecologic oncology at the Gynecologic Center at the Department of Obstetrics and Gynecology at the First Faculty of Medicine Charles University and General University Hospital in Prague. And Professor Henrik Falconer is the head of gynecologic oncology at the Karolinska University Hospital, and he's also an associate professor at the Karolinska Institute. Professor Falconer, could you please explain us the embryological and also the oncological principles behind TMMR and how they differ from the standard treatment for patients with cervical cancer?
But once the tumor disseminates beyond the original organ, in this particular case the cervix, there's this notion that the spread is random, and it's not it's strange that we have these thoughts, because sometimes, especially if you look at the ovarian cancer and you open up an abdomen, it looks like it's just random spread. And this belief is also for cervical cancer. But what Michael Höckel has done for the past 30 years is to try to provide us with more data to allow us to understand better the progression of cancer. And it's not, according to his theory, not by random, but rather it's stepwise process, a permissive stepwise process within cancer fields that are formed by the embryology that forms the organs themselves. So in this case of the cervix and the uterus, it's the Mullerian compartment. So within the Mullerian compartment, there's going to be cancer fields where the progression of cancer occurs step by step, rather than just like an explosion of cancer outside the cervix. And this concept, this idea, is supported by a lot of his studies, and also enables us to tailor our surgery according to these embryological principles. So we don't rely only on anatomy, but also on these principles. So it's both understanding the progression of cancer, but also to understand how should we operate these patients.
Oh, great. Professor Cibula, radical hysterectomy has been the cornerstone for treating patients with surgery with cervical cancer. Do you think that these new, if people call it, approaches like TMMR could provide any advantage for those patients receiving standard treatment with radical hysterectomy?
Well, first of all, I'm very grateful for this discussion and for this session, because for the future of radical surgery, we need this facilitation of the surgery as the treatment modality in cervix. After the hour discussion between me and Henrik, I must admit that there is a lot of agreement between us, and the principle of that is that surgery as a regional treatment and local treatment can be trusted as a solo treatment in early stage cervical cancer. What is the matter of the discussion is exactly what you ask, whether the difference is the TMMR as a different principle, and this I don't buy completely, and for me TMMR represents a very good quality of surgery, and it's not different from what we do, and it's probably a combination of both radical hysterectomy and very meticulous lymph node dissection. And I very much agree that one of the uniqueness of the cervical cancer is the way how the tumor is spread. So one is the growth, which we can see on current imaging. So we know where the disease is, but the way how it's spread, it almost always at the beginning of the disease, it's spread by lymphatic channels. and within these lymphatic channels is very standard way. In the Centix recent prospective trial on 700 patients, there was very regular spread of first to the low pelvic, then to upper pelvic, and then to para-aortic. So because of this predictable way of spreading, the regional treatment, the local treatment, the surgical treatment may play so essential role. So I fully agree with the concept. I fully support it. I'm just saying that we maybe talk about very similar thing. Good surgery, meticulous surgery, both radical hysterectomy or TMMR or whatever you call the concept, and a lymphadenectomy.
Right. Henrik, could you please share with us or explain us the main results of the available evidence we have for TMMR?
Yeah, so that's primarily based on it's Michael Höckel's single center experience, which he has published repeatedly. The most recent publications came a couple of years ago with mature data from a large, again, single center but prospective data showing astonishing results from surgery alone. And I think one of the key features here is that he does not apply adjuvant radiation, regardless of any types of risk factors that are discovered at final pathology. So even if it's intermediate risk factors or high risk factors, he does not give them double treatment. So I think this is something that deserves attention, of course, because this is what we want to avoid in young women, of course. If we can treat them by surgery alone, much can be won. For many reasons, of course, both for morbidity, but also for sparing radiotherapy as an alternative treatment for a recurrence. So what we have been discussing for the past years together with Professor Höckel is to join forces, because it has not been controlled before. It's just a single center experience. So in our study together, we conducted a cohort study with patients treated according to international guidelines and his principles. And what we discovered in this study was that for early stage disease, there was a significant difference in recurrence-free survival favoring TMMR, which was, slightly surprising to me. I was probably expecting similar survival. So that was an eye-opener for me to see that, that type of surgery could actually be beneficial for the patients. However, I think, again, as David just said, we probably agree more than we disagree. And my concern currently is that, we're seeing a decline, which is good, of course, decline in the incidence of cervical cancer. How do we make sure that we can maintain the quality of surgery and also to continue to develop surgery? Because I think at the end of the day, surgical quality and the way that we deliver surgery, it matters. It absolutely matters. For poor surgery, clearly you will need more things. If you conduct poor surgery, you probably need radiotherapy, chemotherapy, whatever. But I think the point here is that we can show that with good surgery, with high quality surgery, you can treat these patients with amazing results as the only treatment option.
Oh, great. And for you, Professor Cibula, one of the advantages Professor Falconer said is the avoiding of use adjuvant treatments for those patients. And I know the answer in part for you, but did you know that we're using right now more adjuvant treatments than we need for those patients after surgery, both for intermediate risk, but also for those patients with high risk characteristics after a radical hysterectomy?
Yeah. Well, I've been criticizing and discussing this issue since many years. That it's been always my feeling and based on our own experience that we overtreat a lot of patients with these intermediate factors because the evidence which we have from the SEDLIS trial is quite old, and our selection of patients is nowadays definitely different than 30 years ago. So, and this is, in my opinion, the explanation, the rationale. That simply intermediate risk group nowadays is very different than intermediate risk group 30 years ago in the SEDLIS study era. Well, again, I very much acknowledge the data from TMMR. At the same time, there are similar data using radical hysterectomy. So again, I don't think that the answer lies in this embryological concept, but the answer lies on the quality of surgery. And I had an opportunity to assist Michael Haeckel once. Don't get me wrong, I really admire he's a phenomenal surgeon, both in the pelvis, on vulva, and it's fantastic. So his radical procedure is really extremely meticulous, detailed procedure, and this is obviously the answer for so outstanding results. The only thing what I would like to emphasize here is that TMMR cohorts, they are too good. If you mention these locally advanced or high risk tumors, they are too good to fit to a standard locally advanced group. So obviously there was some selection process, and we see it in distant control, because distant control is extremely good in TMMR, and it's difficult to argue that any resection in the pelvis will improve your distant control. So we cannot say, let's go to operate, all of the locally advanced tumors from now. It would be really premature. Here we need more evidence. At the same time, if the question is, can we achieve with the surgery similar local control as with radiotherapy, why not?
So, and the next question is for both of you. Do you think that with the evidence that we have right now, but with also complexity for these type of procedures, are we going to have a randomized control trial for this intervention soon, or do you think it's not possible to do that?
Well, that would obviously be, if we look at science in general, to establish something as the new standard, we would like to have randomized trials. But I don't think, especially in Europe, with again, declining incidence of cervical cancer, I don't think, to be honest, that this is a feasible option at the moment to randomize. It would also require substantial, training and so forth. So it's unlikely that we'll be seeing. We have been discussing this with Professor Haeckel, but I don't see it as a realistic option at the moment. What is the future? It's hard to say, but I still think it's not too late. It's never too late to keep on pushing the boundaries for what we do. Now that's what I with David as well. We never sleep in terms of constantly refining what we do. And as I showed today, what we have done in the past 2 decades is remarkable. Looking at survival for cervical cancer, going back to the old trials conducted in the 90s versus what we have been seeing the past decades, it's a remarkable improvement in survival. So we are doing something good. But for the future, I think we need to rethink. We need to look at centralization to have adequate volume for our fellows, for our surgeons in the future, but also for us, seniors to stay curious and keep pushing what we do. Never rest in this perspective. There's more work to be done.
Easy. I agree with everything with what Henrik has concluded. and I also am very skeptical to a possibility to do a proper randomization in this aspect for many reasons. One of them is that you would have to really standardize everything around, which is almost impossible, because the outcome is not only about the surgery. The outcome is about diagnostics, about the strategy of adjuvant treatment, and everything together. So it's much more difficult than just to standardize the way how the tumor is resected. And second, it's always extremely difficult to randomize into two strategies which are investigator strongly skills related. Because in this aspect, there will be sites which will be master in TMMR. So then probably the radicality or whatever would be
Biased.
better than the other one.
Sure.
So by the selection of the sites, you, of course, it's the major bias.
Yeah.
So those are many reasons among. So I believe what we all can agree is that the quality of surgery matters, and it matters especially in bigger tumors. That's no doubt.
Professor Cibula, maybe the concept of therapeutic lymph node dissection goes in the opposite place, that we're talking about sentinel lymph node dissection with all the evidence that we have now, right now for that in cervical cancer. What are your thoughts on the therapeutic lymph node dissection value that could have for those patients?
Well, again, coming to what's been already said, that cervical cancer has a very regular way of spreading. It makes all sense to try to remove these lymphatic channels, and there is a good chance that within the certain spreads, which if it's only in the pelvis, it's possible to remove the disease, that it's contradictory to SLN. Well, it should not be. So far, we have data on SLN in tumors less than 4 centimeters. So this is how we do it now. If we have negative SLN frozen section in tumors less than 4, we rely on frozen section. But if we have bigger tumor than that, we always do systematic lymphatic exertion.
Okay, perfect. So just to finalize our interview, what would be short take-home messages from this discussion for both of you?
Well, I think for me, and I know it's for David, it's try to stay curious, and just because cervical cancer has been studied for so many decades, there is no reason for us to stop investigating the potential of surgery, and what are the limitations of surgery, and to create structures to improve the quality. That's something we should continue doing. And the second thing is avoid double treatment in these young women if you can, and we should make efforts to really avoid that for many reasons.
Maybe 2 messages from my side. One, for the future, the centralization will be absolutely crucial, because at least in our setting, in European region now, and for this, I admire Sweden and Norway, how they are able to centralize. It's a country of 3,000 kilometers from one side to another one. It's unbelievable. In Europe, it's from here to Portugal, and they are able to centralize patients to one side. It's amazing how effective this can be. So centralization is the key, because if you do 5 cases per year, you cannot train the next population. Yes. Then the destiny of it is that we may once radiate everybody, because radiation therapy will be standardized, while surgery will require skills, and skill require training and the volume. And the second message is similar to what Henrik said. We are Now, living in the era of fascination of new innovative molecules, and it leads us to the trials which want to give to add additional biological treatment in adjuvant setting. So we can easily end up that in these patients for whom surgery alone can be a safe treatment, it looks like we will add radio and chemo and immuno and then immunomaintenance, and it's a wrong concept.
Yeah, I absolutely agree.
Thank you so much, both of you,
You're
for your time and for everything, every good message.
Thank you for the invitation.
Thank you so much.
And